Thanks for joining us to help choose home when care is needed, a podcast all about the value and benefits of receiving care in a place you likely feel most comfortable, wherever you call home. I'm your host, Marilee Orsini, and I've been involved in healthcare at home since 1981. Each episode, I'll be talking with a guest who will help us in our quest to educate about healthcare at home. So let's get started on today's episode number 19. Our guest today is Alan Hager, and Alan is Executive Chairman of Risemark. Now, you might know Risemark as one of its three wholly owned subsidiaries, Right at Home or Right at Home International, or IKOR. And these three subsidiaries actually serve more than 500 territories globally. But Alan, as Executive Chairman of Risemark, is actually also the founder of Right at Home. And as a founder of Right at Home, one of the things that most interested me about him was that while he was deciding to start his business, he actually got certified as a CNA, Certified Nursing Assistant, and he worked in the industry so he could find out what some of the issues were from the inside. So let's welcome today's guest. So, hey, Alan, there's so many things that interest me about what you are doing with Right at Home and with your Risemark brand, but I want to start with the study, the Harvard Medical School study, that is, as I understand it, trying to determine if home care can actually make a difference in the numbers for patients who are admitted or readmitted to the hospital.
Yeah, well, what we call the Harvard study, now my understanding is the Harvard people call it the Right at Home study, so I think that's kind of interesting. But it's really, if you think of home care and its place in all of health care, this has been an ongoing development. I know you've been in longer than I have, Marilee, and understand the place that in-home supportive care is taking in the whole continuum of health care is changing dramatically. And there's a lot of reasons behind that. It's a great way to get care. People want to stay at home, and there's a lot of consumer-driven ways. But the core, I think, of where that's coming from, quite frankly, is dollars. If you look at, the American healthcare system does a lot of wonderful things well, but as Dr. Atul Gawande, the famous medical writer, says, the U.S. healthcare system is wonderful, but its most egregious fault is cost. It's with the growing aging in society, it's just way too expensive. So one of the things that we wanted to show, we've had a lot of work showing that we improve quality of life, and people love getting care at home, and it's improving their quality of life. But very importantly, we wanted to begin to look at the issue of, well, what happens in the overall cost of the delivery of care when you look at chronically ill people and how they receive their care? A few years ago, we actually did a study together with the Forsyth Medical Center. It's down in Winston-Salem, North Carolina, is where they're headquartered. One of our offices participated. It was under a Duke Foundation grant. It was about a year and a half long study. And in a nutshell, it showed when you begin to bring supportive care services into the home for older, chronically ill people that are being discharged from the hospital, it became very clear the unnecessary readmissions were dramatically reduced. And within 1 year, I think that medical center saw about a $1.4 million reduction in overall cost that they, if you look before and after, they introduced the services. So that really spurred us to think more about, it's our responsibility as a large provider of home care, not just in the U.S., but now 7 other countries. How can we go deeper on taking a look at how the services we deliver affect the overall cost of care? So together with our technology provider and the Harvard Medical Center, we put together a study that's been ongoing now for about 3 years. And the results are just coming in. I know those are going to be delivered here a little bit later this year, but I think the preliminary results certainly are heartening to us of what we're going to be able to show. When you introduce our kind of services into the home, you actually overall reduce the cost of care. We've actually gone back and got Medicare data from the people that we've cared for with their permission, and we showed we had it was very rigorously designed study, as you would imagine, that Harvard does, and we showed those that were receiving the type of care that we're talking about here and those that weren't, and looked at the difference. And it looks like the preliminary results, and I haven't seen the full study results, is that it really does reduce the overall cost providing care when you do introduce the supportive care services into the home, and you begin to really manage effectively changing conditions and other kinds of things as they come up.
You're talking about the overall cost of care, what a patient cost would be, and that includes everything. But was that a surprise to you that by using some we call non-skill services for the consumer, that doesn't mean these people aren't trained, it just means they're not nurses. But was that a surprise to you?
Oh, absolutely not. I mean, anecdotally, I was in hospital healthcare administration for years before I got into home care, and when you take the whole broad panorama, I mean, I was involved in government policy before that, so I've kind of had some experience in looking systemically, not just individually. I mean, I've felt all along, and many of the colleagues that I've worked with, when you began to look at the things our health system does well, big dramatic interventions with medical technology or surgical technology, imaging technology, big dramatic interventions work extremely well. Where it begins to fall apart are those social determinants of care in the home, and where the clinical ends at the hospital door, and now they go home and they're not eating right. The medications fall apart. It's oftentimes very complex medications. They're in a stressful environment. They just don't get the appropriate socialization that they need and all of that. They don't go back and go to their primary care visits for follow-up. Those are all things that in-home care, in the supportive care, even without a skilled component attached to it, if it's done well, if it's done in a professional way, it absolutely results in just a lot of things that are happening that reduce the overall cost of care. I mean, I could give you two easy examples, and these are out there in the literature. Two of the things for older chronically ill people, two of the most expensive things are medication interactions, where they're either not taking their medications appropriately or they're taking it or not adhering to their medication regimen is one, and the second is falls, where you have people for a number of reasons, improper nutrition, the wrong environment, not getting the right kind of supervision, etc., where they're falling. And this is always going to be an issue with older chronically ill people, but it can be greatly reduced when you introduce in-home supportive services. So just those two things alone certainly would introduce an environment that could lessen those kind of negative outcomes that I just talked about.
One of the things that it looks like to me is, if you distill this down, that what a caregiver is looking for in the home is actually some type of change of condition in the patient.
Yeah, I mean, I think that's one component. I mean, I think you're looking at and I think that's been one of the misnomers, misapprehensions that we deal with a lot in our industry, is that because it's not heavily clinical, well, it's easy and it's simple. And that's absolutely false. You're talking about the human condition. You're talking about people in their home environment. You're talking about less control, if you will, than a clinical environment. But this is how people live. And now with wonderful medical technology, they can maybe live in that environment for 10 years, 15, 20 years. So when you begin to do that, when you introduce well-managed in-home care services, as you mentioned, certainly changing condition is one aspect of that, but a real professional overview of the entire environment that a person is living, the psychosocial, emotional, and even partly the clinical environment, because there's such an overlap now, I think, between the two. So it's a whole combination of attracting and retaining and training the right types of caregivers, that you have an excellent care assessment methodology, and that you also have the appropriate care in the appropriate way at the appropriate time. And as you say, the changing conditions, reporting that up on a daily basis, really closely observing. I mean, let's face it, again, human beings, we're not machines. We kind of have good days, bad days, and everything in between. Well, when a person is already somewhat frail and weakened because of chronic illnesses and they're living in the home environment, and then you introduce some dementia where they really can't verbalize it or don't have good judgment about some things, it really requires a whole symphony of a carefully laid out care plan together with people that can execute on that and a rigorous oversight that ensures that that's going to happen over a period of time. And a very important part of that, I do believe, is as a daily, is the change in condition, because that is what leads to some of the negative things that we talked about, and where we can now be a partner with the traditional health, I'll call it the traditional healthcare system, either the specialists or the primary care physicians or even the skilled nursing judgment, where that information isn't delayed into an office visit a month later or to an emergency department visit so often, that it is relayed immediately and an intervention of some type occurs that can head off what would have been a negative outcome.
I know that in the Forsyth study, you had, and Right at Home had an actual agreement with the hospital. And in this Harvard medical study, obviously you've got designated sites where you are tracking and monitoring this. But overall, it sounds like that the care management component or the more extensive management of care, and I know I'm going to regress a little bit because I know that IKOR is one of your products. It is a care management product, but can you talk about from a consumer perspective, what is that care management component, and is that one of the missing ingredients in our healthcare delivery system?
Oh, well, in my opinion, first of all, yes, we do have a whole separate life care management, which includes geriatric care management and other components to it as a separate service. But even our in-home care provision, I think any good in-home care provider, you have to have a good overall assessment. Now, when you look at true geriatric care management, that can be much broader than just the in-home care. Now you are taking, you're going a little bit step broader at all the needs of the individual, maybe even before they possibly need in-home care. But I think for families, it's a wonderful service, and if it's done appropriately, like everything else. But it can be a wonderful way for a family to get their hands around what are we looking at, whether it's the person who needs the care themselves or the spouse or the extended family. What are we looking at here? And when is that really appropriate to have done? Well, anytime I think a family or the individual is starting to feel that kind of a bit out of control. They're starting to see the chronic health care issues that are disrupting life, that are causing additional problems. Well, this is just, if you were having that in a financial way or a legal way, we know what we would do. We would hire the right professional. Well, I think geriatric management services are just as important, or even maybe more important to the overall quality of life for an individual. And actually, much of our work, or much of our referral, particularly in our geriatric care business, does come from financial or legal professionals whose clients have come to them and said, well, gosh, I have all these other issues too, and it's beyond the scope of what they do, and they refer them to us.
For a family member with a loved one who they think has a care need, what would you say would be their first steps to take?
Yeah, I think the first step is, we're in today's world, obviously we have a massive online, treasure trove of good information. And you can get out there and begin to look initially. Now, depending on the kind of person, many people like to start there because they can gather in data, get their questions together. But what they ought to be thinking about is a whole range of issues, everything from will this individual be able to stay in the home? Do they need to move to a more institutional type setting? That's obviously a gigantic question. Is the appropriate care being given? And that can be an extremely complex issue. So oftentimes elderly folks, older individuals that over a period of time have kind of gotten this kind of patchwork, I would call it, of healthcare going, a specialist over here, primary care over here, pharmacists, other components, and now they have a whole range of issues, and maybe they have 3 specialists involved, and they have 2 pharmacies, and they have, just this patchwork quilt, and there's no central coordination of someone that's really looking at that. So I think the family member has to take a very hard look at that. I mean, the medication, the pharmaceutical technology we have today is phenomenal, but I particularly see in older adults with a range of chronic care conditions, who on, by the way, our clients I know average about 8 to 9 medications. It can result in a whole range of problems itself. So you see, it's a complex issue. So I think number one is if the person feels qualified for it or comfortable with it, is taking a hard look at themselves, at the clinical as well as the social aspects of the person that needs the care, and do a little bit of online research. But then go to a trusted source. I think you can certainly, there's a whole range of geriatric care managers that are out there that can help with, but you can also go to other, there are social services, there's the area agencies on aging. It could be a trusted social worker within a healthcare setting that your mom or dad has been involved with. But is getting someone you trust to begin to direct you at what the alternatives are.
And you made a statement to me about that much of the future of home care will be driven by the healthcare system's need for low-cost, high-value services. Can you speak to that and what that portends for our future?
It's probably, if you think of us, I'll put on my, I'll take off my home care hat and put on my citizen hat and think of it from a public policy perspective at the highest level. We cannot afford as a society keep going the way we're going. If you think about Obamacare and all the things surrounding that over the past 7, 8 years and before and after it passed, and it still goes on, why is there so much political turmoil? It's because the stakes are enormous. I think most public policymakers, even at the very highest level, if you sit down with them, they will tell you, well, Social Security, we can do some adjustments, and we've got that, and we think we can take care of that. You start talking to them, even, other types of entitlements, but you start talking to them about Medicare and Medicaid, the way that we as a society, as a government, pay for healthcare services, and they are frightened to death. There really is no solution that anyone has seen yet on the trajectory of those cost increases. They just keep coming. When I first got into healthcare administration, everyone thought it was atrocious that 8% of our whole gross domestic product was spent on healthcare. It's now almost 20. So, it can't be 100. We all know that. We have to build roads, we have to have schools, we have to have, defense and other things that we do and pay off our debt. So it's really a societal issue at the highest level of how do we begin to look at this promise that we've made to older adults and not just older, but those without any resources, to provide their care, both acute care and in a long-term care setting, particularly in a society where 25% of us, which will happen very soon, will be over 65. There's very few things that you can say that never in the history of civilization has this occurred. Well, this is an example. Never in the history of civilization have we had a society with so many older people. And then you follow up on that with wealthy societies like our Western democracies. We've all made promises. We're going to take care of you. We're going to provide care. So I'll get off of the public policy and say, okay, how does that really affect home care and health care? Well, one of the things that I think we're beginning to show more and more, that this very, very important problem, providing care for people as they age and as they need, a whole range of health services. One of the important pieces of that certainly are people that are well over 65. If you look at Medicare, there are a group within Medicare, 5%, that equals half of the cost. So So it's pretty simple to see where you start. How do you start looking at reducing cost? You have to change the way you deliver care in some ways to that 5%, because that's going to equal a lot of change in the lowering of cost. Well, essentially, the people we care for in their homes that have multiple comorbidities, as we'd say, and a whole other range of chronic care challenges, that is who is that 5% that equals 50% of the cost. And I think what we're beginning to show, and I think Harvard, and there will be other studies as well, show that part of the solution here is don't keep sending them up to the big box, as we call it, the hospital or the emergency department, and back and forth. Don't put them in these extremely high-cost settings. Provide basic supportive care, maybe a social type of care, and that will reduce the overall expenditures in health care. So that's why I say, and I think that's going to, we could talk through a whole range of ways. Technology is providing an enormous benefit, as it has in every other part of our lives. We will be able to leverage technology more and more for being able to provide that care in the home, not just as companies or organizations that provide the care, but for consumers who could use these technologies as well, and empower them to be able to do more of their own care in the home. So I think if you look at the three things that I would say that are major forces that are driving this: how consumers live, and the fact that more people want to be able to stay in their home and not have to leave their home for institutional care. That's one. The second thing is government and the enormous growing pressure that government has on finding a less expensive way to provide care. And third, technologies. Technologies, just as now technologies allow you to get, when I first got into the hospital business, if you got an open heart surgery, you were there for 12 days. Now you're in and out in about 3 or 4. Why is that? Well, it's because the way we provide that care and all the technology that supports it has allowed us to do that. And so I think those three things really portend a healthcare system where much more of the care, particularly for older, chronically ill people. Now, if you break your leg, there's a good reason you got to go in the hospital, or if you have a major heart attack or some other huge acute event, there'll always be a place for that. But for so many of the problems that older, chronically ill people have, it's totally inappropriate that they have to leave their home and all the disruption that occurs and the cost that's with it.
Alan, I know that you travel extensively and also are very active at a national and international level in terms of healthcare delivery systems. The simple equation of helping someone choose home as an option seems to be gaining some recognition within the system. Are you noticing a change that a consumer is having an easier time now getting a referral or having a discharge planner or a physician suggest home care?
No question about it. You know, we were, I call it the poor stepsister of care, 25 years ago. It was just a matter of there wasn't a real understanding that this in-home array of supportive services could be so helpful and important to people who were aging in place. And that has included professionals. Quite frankly, it's still quite an issue. But in the intervening 20, 25 years that I've been in this particular business, almost 25 now, there's been a seismic shift in the recognition that if you look at the whole continuum of care services, from the most simple kind of primary kinds of things all the way up to the most extensive, that we now have a place that is important in that. And referral social workers, geriatric care managers, those who work with families of seniors and those that are beginning to have challenges, are really recognizing in a much broader way. That's part of it. The other piece, quite frankly, is I think the incredible communication that has happened. I mean, the increase, and particularly in the online world, and the ability for consumers to go right to the the source. And a lot of companies like Right at Home and many others have put an enormous amount of information out there to help consumers with their decision making, with trying to figure out what they need to do in terms of if they do get some kind of care in the home setting. So you kind of put those two things together, and I think we do have a lot more recognition now.
And I have one last question. This really has nothing to do with American consumers, but my curiosity. You are in 7 different countries now. What differences do you notice in either the acceptance of home care services or the provision of home care services that would be cultural differences from country to country?
Well, I tell you, it's a question obviously I've been working on for many years, Marilee, and the same thing is happening. I mean, we're in the UK, Ireland, Canada, the Netherlands, Japan, Australia, China. All of these countries extremely different, the different structures in their healthcare systems and the payment systems that they have, very different cultures, period, about how they see older people and care and so forth. Particularly Asian countries are well known, for example, for, well, we take care of our own, we care for them. Well, those days are over, or certainly are on that way, just because of the size of the problem. I could just give you a couple of examples. Japan right now, we fear, going to 25%. They're there. They will surpass 30% before too long. And they don't have a lot of immigration or other people to come in the country to provide, additional care source for caregivers and so forth. They are desperately looking at ways, and it's way beyond the families. Their birth rates are very low, so they don't have a lot of family members, and they're having lots of challenges. China, traditionally, people had just 30 years ago, people were having 5 children, and families who took care of their folks at home and so forth. Well, that's over 30 years ago. In today's world, China is looking just as aggressively at how we are going to take care of folks. Now, I'll tell you an interesting insight that I heard from, I'm forgetting his name now, but